All right, so getting into pharmacodynamics. The dynamics is the mechanism of action or the mode of action. How is this drug performing its function? You're going to have your primary effect or your therapeutic effect, which is the effect that is desired. But a lot of your drugs also have secondary effects, which can be desired or undesirable. There are certain drugs that were designed for one function, but we see that they also do a second function, and so they can be prescribed sometimes off list for this second function. It's a desirable one that is not the primary effect. Think of some secondary effects, though. So what is a drug that you take and then you'd hear that it has secondary effects? You probably think of like side effects, right? So what are some common side effects? Probably like drowsiness, right? Sedation, nausea, vomiting, constipation. Those tend to be side effects that we're like, yeah, those are pretty reasonable side effects. Something else that goes with pharmacodynamics is how long does it take this drug to work? How long it takes to work is going to be the onset. So how much time does it take for the minimum effective concentration? How long does it take to start seeing an effect? That's onset. Then you have peak. How long until it peaks, until you get the highest blood or plasma concentration before it starts to drop down? Duration, how long does it hang around? So when we're talking about liver disease, we're like, the half-life on these increase a lot if the person has a liver disease. And so the duration of that drug is going to increase because the half-life has increased. Something else to think about when you're thinking of pharmacodynamics is how does it get into the cell? How does it activate the cell? For a lot of your cells, you're going to find the receptors on the cell membrane. So here you can see an opioid receptor right here, calcium channels, GERK receptors. And so you have these different types of receptors. The four major families that we're going to be talking about are channel-linked receptors. Channel-linked receptors, again, you learned about this in physiology. There are things like acetylcholine nicotinic receptors are a channel-linked receptor. Your GABA receptors are channel-linked receptors, so when you activate them, they open up a channel, like a sodium channel or a chloride channel. G-protein coupled receptors are probably the most common. There's a lot of those out there. While your acetylcholine nicotinic receptors are channel-linked, your muscarinic ones are going to be G-protein linked. Also, when we talk about some of your adrenergic receptors, some of those are G-protein linked. Kinase linked. The only one that I can think of off the top of my head is tyrosine kinase is linked with your insulin receptor. And then you have nuclear hormones. And so for these, the receptor is not on the surface of the cell, but actually inside the nucleus where they bind to DNA and act as transcription factors. There are things that bind hormone and DNA together to activate these. An example would be any of your steroid hormones have nuclear receptors, so they're nuclear hormones. Also, T3, T4 act like nuclear hormones, so they're also nuclear hormones, even though they're not steroid hormones. So, receptor theory, a way some of these terms that we'll get into is your receptor is going to produce a response when the natural chemical binds to that receptor. So here you can see the natural chemical binding and activating a normal cellular activity. You can have agonist and antagonist to these drugs. So an agonist is going to bind to that receptor site just like your natural chemical will, and is going to enhance cellular activity just because there's more of it, right? So say you have X amount of this natural chemical, you add in an agonist drug, that is going to increase at least what your body is perceiving as this natural chemical. Then you have antagonists that block the receptor. So they're not going to enhance the cellular activity. They're actually going to stop the agonist or the natural chemical from binding and not making an action. Again, we talked about most drugs have these secondary effects, these side effects, which gives us these terms called therapeutic index and therapeutic range. When we're talking about therapeutic index, we're talking about the margin of drug safety. There are some drugs that have a huge margin of safety. This is going to be like a lot of your over-the-counter drugs. Like, you can take a lot of one drug and still be okay. But there are other drugs where you can take very little of this one drug and not be okay anymore. And so that is talking about the therapeutic index. So if a drug has a low TI, if it has a low therapeutic index, it has a very narrow safety margin. It is a potentially dangerous drug. You do not want to give somebody too much morphine. That is not good. It is a potentially dangerous drug. If it has a high TI, well, that means it has a wide safety margin. It has less danger of toxic effects. You can take a lot of this drug where you are meeting the minimum effective concentration and not exceeding the minimum toxic concentration. And so it has a really wide therapeutic range. So, therapeutic range. And something with a high TI is going to be very broad, where it's effective at a low amount and it's toxic at very high amounts. With a low TI, you're going to have a very narrow therapeutic range. So it's like, okay, it starts working here, and here it will kill you. So very narrow therapeutic range. Again, with these secondary effects, sometimes we call them side effects or adverse reactions if they are things that we do not want. Typically, when we're talking about side effects, we're talking about things that are not related to the drug effect. So things like nausea, sedation, dry mouth are like side effects. They're not going to kill you. Adverse reactions would be something like persistent diarrhea, persistent vomiting, confusion. Death is a pretty big adverse reaction. Breaking out in hives or anaphylaxis are very intense adverse reactions to these drugs. And then, of course, toxicology, right? So the harmful effects of this drug on living tissue. That's basically what toxicology is. And, the difference between a drug and a toxin is dose. I think Periclesius, some middle-aged scientist, was quoted to saying, like, the difference between a toxin and a drug, and, like, a medicine and a toxin is dose. All right. We will pick up with geriatric pharmacy or pharmacology in the next group.